To be honest, the triangular technique can be dangerous. It works well for some surgeries, but with others it can place you in a dangerous area. The safest way to mark your incision is go by the anatomical position of the uterus. The first position you need to palpate is the most cranial part of the pelvis, the iliac crest. For an adult cat, you want to mark an imaginary line. One finger in front of the iliac crest. If you go further, then the bifurcation will be difficult and the spleen may be present. For young cats, I tend to go half a finger or less. The reason for this is that finding the second immature uterine horn can be very difficult, especially if you have gone too cranially. The next position is in relation to the spine. The uterus sits about 1 finger below the spine. If you go higher, you risk entering the retroperitoneum. As well as the major vessels, we have the ureters. If this is entered, then ureter damage is likely to occur. As well, vets have removed a kidney and ureter, thinking them to be ovary and uterine horn. An experienced friend of mine did exactly that, and removed a kidney and ureter by accident. So I place a finger just in front of where the pelvis ends and make a dotted line down. I then place my finger below the spine and make a dotted line. The vertical line marks the middle of the incision, and we must not go above the horizontal line. I make a diagonal mark. The reason for this is the top part is a little closer to the ovary, and the bottom part closer to the bifurcation. It probably doesn't help much, but explains why the line is diagonal. The incision side is usually about halfway down the cat. Sometimes I will lift the drape to check this, and if not, I will check my marking. The biggest mistake after marking your incision point is not to move the skin after marking. If you watch the more detailed video, Avoiding Ureter's Flank, Cat Spay Neuter, this video is more in depth. I check the mark again and make an incision through the skin. A number 15 blade is best. With a number 11, I am more likely to cut too deep. Watch how I hold the skin, but I am careful not to move the position of the skin. I now lift the fat and make a small snip. After this, the fat is raised again and blunt dissected down to the muscle. It is important to cut out a fat window where you can visualize the muscle. The main reason for this window is so the abdominal fat is clear and not confused with the subcutaneous fat, and improve visualization of the abdomen. Sometimes you will nick a vessel in the fat, which is usually top left of the fat window. This often bleeds quite significantly, but his usually stops fairly quickly. Very rarely I have had to ligate the vessel. There are two muscle layers, the external muscle, which is thinner, and the more caudal you go, the muscle thins to just a sheet. The internal muscle layer is thicker. This is because there are two muscle layers, fused to become one. Sometimes the internal muscle separates a little, and the two layers can be seen. A small snip is made in the external muscle. As we want this snip to be central to the wound, we grasp the muscle where we want the snip to be. Then grasp the muscle to the left with another pair of forceps, then you can make the snip centrally. The internal muscle is then grasped and pulled through the external. Another pair of forceps holds the muscle to the left, so the snip will fall centrally. As this muscle is thicker, a few snips may be needed, or one bold snip. It is essential the peritoneum is entered. Ideally, this happens when you make your internal muscle snip. And when the peritoneum opens, it looks like cling film with a hole in it. If the peritoneum is still intact, you will not be able to grasp the uterus, and instead you will just be picking up bits of fat. What you need to do is tear open a window. To do this, pick up some abdominal fat and tear one open. Once this is done, the fat will look wider. It is important to make this window before you start looking for the uterus, as it is harder to make if you have been fishing around for a while. If you have carefully marked the incision point, as instructed, the uterus should be directly below the incision. Uterus and ovary. This is abdominal fat, as it is more stringy. The uterus will be above this fat. This is the lumbar fat bad. The uterus is below this. This is a young cat, pre-first season, as the uterus is small. But note the ovary is not proportionally smaller. Place a pair of mosquito forceps below the ovary and push the clamp as low down as possible. Make sure you fully clear the ovary. Just do one click of the clamp. This is a quick spay technique, but if there is not enough clearance of the ovary, then the ligation will have to be placed below the clamp, and if so, rotate the clamp to the right, away from the body, and form the ligature with the knot on the left. This prevents any tissue getting caught in the ligature. Most importantly, the entire ovary has to be fully removed. Otherwise, ovarian remnant syndrome will become a client nightmare. I quite often use Alice tissue forceps to stabilize the uterus so it's not flapping around. The pressure in the ovarian vessels is less when compared to a dog's, so classical surgeon ligations are placed rather than Miller's. I tend to use metric USP30. The ligature needs to be close to the mosquito forceps, so there is a good clearance of the ovary. I have used this technique many thousands of times, and the mosquitoes have never broken the ovarian vessels. You can visualize the ligature to check the tightness, and if unsure, add another ligature close to the first. I remove the mosquito forceps and cut the vessel. Ensure there is enough space past the ligature and enough space below the ovary. This technique only works if you have good clearance of the ovary. So if clearance is poor, ligatures will have to be placed below the clamp, the traditional Cat Spay technique. Remember to place a clamp on the uterus so she does not bleed out. Never place a clamp on the ovary, as there are a few opinions who believe clamping the ovary will result in ovarian seeds, which will fall into the abdomen. And where these seeds fall, ovarian tissue will grow. I have seen zero evidence of this, even after mentoring 50,000 cats performed by new graduates. So the next step is to find the other uterine horn. First, break down the broad ligament by tearing it, but be careful not to damage the uterine vessel. Sometimes, especially in older cats, the bifurcation is easily visible. But in younger cats, like this one, you have to use forceps. I find curved forceps greatly helps. Remember, the second horn will run parallel with the first, but will be deeper. Use your blunt forceps to part the fat and look for the horn around the base of the first uterine horn. You can pull gently on the first horn to help raise the second. If you repeatedly find this difficult, you would be better to make the incision more caudal in your next spay. The procedure for the second horn is identical to the first. Remember to place the ligature as close as possible to the mosquito forceps. it is not possible to reach the bifurcation. And it is not necessary to make a massive wound to get to the bifurcation. So we ligate the horns separately, placing 2 surgeons on each. On a risks vs benefits basis, 1. Do not use crush beds. Due to the risk in older cats of the uterus falling to pieces. 2. Only use millers in pregnant cats, due to the risk of the suture cutting through. 3. In older cats where the uterus is more fragile. I place the first surgeons at about 85% strength and the second 100%. 4. When the uterus looks gray or white, this is a sign the uterus is fragile. Now just snip off each horn. The size of opening in the internal and external muscle is different. This is why these layers should not be closed as one, and should be closed separately. I close with cruciate mattress sutures, as this gives you an advantage, which you will be able to see now. Many new grads close the external thinking it is the internal. So first identify the external and then grasp the internal below. Do this on the right, caudal side of the muscle. Then pick up the left and pass the needle through. This is your first pass of the cruciate. Now watch how I use the suture material and tail to lift up the muscle, making the second pass much easier. Now tie off the cruciate, make sure it is snug, not too loose or too tight. Despite its stigma, cat gut has excellent knot security, and its ability to control the knot tension makes it my first choice over PGA. For old stray cats, which have had several litters, second choice for the same reason is coated PGA. Personally, I avoid monofilament, as I find it difficult to get knot tension as I would like it. We all have different reasons for our suture choice. So I keep a long tail on the first cruciate and use this tail to lift up the muscle, so I can easily pass the suture for the second cruciate. After the first pass of the second cruciate, I then snip the previous cruciate's tail. I keep repeating this until the inner layer is closed. This saves time, so you don't have to keep using forceps to find the internal muscle. Now I am raising the internal muscle to check it is fully closed. It's only a small hole, but I place a single knot. With catch and release, here is no cutting corners. Once released, they cannot have any post-op problems, because they are impossible to catch again. We now have to close the external muscle, either with cruciates, continence, or an interrupted pattern. Exposure is much better regards the external muscle. Quite often it is difficult to close the external neatly, it often looks dog-eared. This time I am closing with a continence pattern. Watch how I use the suture material to raise the muscle, making it easier for its second pass. We each tend to have a preference, regards whether we start the intradermals from the top or the bottom. So start the fat closure the opposite way to your preference. The fat is closed with the continence pattern, but it must not be tight, just bring the fat together. Occasionally some vets will take a partial bite of the muscle midway with the fat closure. This helps reduce dead space and potential seroma formation. The fat can be hard to get to. My best advice is to load your needle holders, put them to one side. Then use 2 pairs of forceps to find the fat, then pass the needle through the right side. Then again load them and find the left side of the fat. Once you have tied your knot, the fat will be easier to grasp. I have seen new graduates get very confused with the fat. This is when it has bled at the start and now has a hematoma. So it can sometimes look more like muscle than fat. Be aware of this, as it should save any confusion. We now go straight into the intradermals. You might worrying that the anchor is in the fat. But it is the physical size of the knot, which can't be pulled through the skin. Try and leave a small hole at the end, so burial of the knot will be easier. I tend to always make a long knot by placing a large number of throws. The reason for this is that I find they bury easier, and also they are less likely to pop back out. Aberdeen versus surgeons. Recent investigations have shown quite a few Aberdeens unravel and result in the wound opening. This does not happen with a surgeon's knot. If you use an Aberdeen, when you finish the knot, pass it through twice. This reduces the chance of a breakdown. You must bury the knot. While pulling the suture, also push the skin over the knot with essence. This will result in a lesser chance of the suture snapping. When you feel that tug, you know the knot is buried. If the knot does not bury, it sits between the skin edges. This means this area of the wound cannot heal by edge to edge. And a few weeks post-op, when the suture has dissolved, you can be left with an area of wound breakdown. If the knot is not burying, it probably means you haven't left a hole for it to bury. Pull the suture back through, and try again. Make sure you are passing the needle just next to the knot and not a distance away. As a last resort, remove the needle to place a larger needle. This will make a passage for the knot to follow.